Good morning, everyone. I am Dr. Bipul Kumar Das. I am an ophthalmic surgeon working with KG Hospital, Coimbatore, Tamil Nadu, India. Today, I'll be discussing something on toxic anterior segment syndrome. So, as per introduction, we say that it's referred to as sterile endophthalmitis or post-operative uveitis of unknown cause. Accurately, it was termed as toxic anterior segment by Monson et al. In the year 1992. There's another entity which is called as toxic endothelial cell destruction syndrome. This is a variant of TAS with localized corneal endothelial damage. Now, as per definition, it's a sterile, acute, postoperative inflammatory reaction in which a non-infectious substance which gains entry into the anterior chamber, and this induces a toxic damage to the anterior chamber structures during anterior segment surgery. Now, as per pathophysiology, it results from an inadvertent entry of toxic substance into the anterior chamber. The histopathological hallmark of this syndrome is anterior structural damage, which could be cellular necrosis, apoptosis, extracellular damage, resulting in acute severe inflammatory reaction in the anterior chamber. The corneal endothelium is the most often damaged structure because it has the inability to regenerate and replace these dead cells. There could be a possibility of trabecular meshwork damage as well, with raise in the intraocular pressure and secondary glaucoma. Now, the hallmark of this TAS is an inflammatory reaction which starts within, say, 12 to 48 hours post surgery. The most common clinical findings of this syndrome are diffuse limbus to limbus corneal edema. There is increased inflammation of the anterior chamber with sometimes hypopyon formation and deposition of fibrin. There will be a dilated pupil with irregularity of the iris, and there could be potential damage to the trabecular meshwork leading to increased intraocular pressures and secondary glaucoma. Sometimes cystoid macular edema may be seen, and the most important thing is this rapidly improves after topical steroid treatment. Now, coming to the clinical course, this may be divided into mild, moderate, or severe presentation. In mild cases, we have rapid clearing of the corneal edema with no long-term corneal or trabecular meshwork damage, and there could be a normal or near normal visual acuity. In moderate cases, there is persistent corneal edema. This may take several weeks to clear. Intraocular pressure that is sometimes difficult to control, and there could be a moderate effect on the visual acuity. In severe cases, there will be marked corneal edema that does not clear. The iris and trabecular meshwork damage will be there with resultant glaucoma, and there could be a possibility of cystoid macular edema. The visual acuity is usually poor despite the medical as well as surgical treatment. Now we should be differentiating this TAS from endophthalmitis. In the first picture, you are seeing a TAS case where you have diffuse corneal edema which is from limbus to limbus. Whereas in the second picture, you can see a endophthalmitis case where the corneal edema is not from limbus to limbus. There is a clear corneal margin which is there at the inferior part of the limbus. Now, as per the timing of the disease, I have already mentioned, generally the TAS will occur within, say, 12 to 24 hours post-operatively, whereas in case of endophthalmitis, it may take from 4 to 7 days, and the pain will be negligible or sometimes mild in case of TAS, whereas there will be severe pain in case of endophthalmitis. Conjunctival and lid reaction will be there in case of endophthalmitis. Lid edema will be there. Intense conjunctival injection will be there, which may not be seen in case of TAS. And corneal edema, as I have already mentioned, limbus to limbus edema in TAS, whereas it is not there in endophthalmitis. Now, iris findings, iris atrophy will be there, pupil will be dilated, not reacting to light, and the intraocular pressure will be raised in case of TAS, whereas in endophthalmitis, these findings may be variable. The therapeutic response in TARS will be dramatic. It will be very fast, and there will be rapid improvement in the clinical signs and symptoms following topical steroid medications, whereas it may not be there in case of endophthalmitis. The involvement of the clinical involvement of the structures will be anterior segment in case of TARS, whereas it will be anterior and posterior segment in case of endophthalmitis. Here you can see in the first picture, it's a B scan where the vitreous is very clear in case of TARS syndrome, and the reaction is limited to the anterior segment. Now coming to the differential diagnosis, apart from infectious endophthalmitis, which was already discussed, we should be differentiating this from retained lens material and uveitis. Differentiating features will be there will be drastic improvement and rapid improvement with the topical medications that like topical steroid and anti-inflammatory drops in case of TARS, whereas it will be delayed in case of retained lens material and uveitis. And this is a tabular differentiating between TARS and endophthalmitis. The cause in TARS is non-infectious reaction to toxic agent which gains entry into the anterior chamber, like BSS solution, antibiotic injection, endotoxin from dead bacteria or residues in the instruments. Whereas in case of endophthalmitis, it's always infectious, could be bacterial, could be fungal, could be viral infection. Onset of symptoms and signs within 12 to 24 hours in TARS, whereas 4 to 7 days in case of endophthalmitis. Signs and symptoms which distinguish it from endophthalmitis: blurry vision in case of TARS, whereas drastic decrease in the visual acuity in case of endophthalmitis. Pain is negligible, mild in case of TARS, whereas there will be severe pain in case of endophthalmitis. Lid edema and lid swelling, lid edema and conjunctival injection, hyperemia will be there in case of endophthalmitis, which may not be found in case of TARS. The anterior chamber, there will be mild to severe reaction with cells flare, hypopyon formation and fibrin deposit, which will be intense in case of endophthalmitis. Signs and symptoms are generally related means limited to the anterior segment in case of TARS, whereas there will be involvement of the vitreous always in case of endophthalmitis, and the aqueous culture and gram stain will be negative in case of TARS, whereas it will be always positive in case of endophthalmitis. Now coming to the treatment, we should always rule out any infection in case of TARS. The culture of the anterior chamber has to be done. Intensive corticosteroid drops has to be instituted, and we have to monitor the intraocular pressure for any damage to the trabecular meshwork with rise in the intraocular pressure. If it is there, we have to control it. In case of endophthalmitis, we have to do culture of the anterior segment as well as the vitreous, and intravitreal antibiotics as well as topical antibiotics has to be instituted in endophthalmitis. And in some cases, we may have to do a pars plana vitrectomy in endophthalmitis. Now coming to the management part, most patients do well with medical management using topical steroids. In rare cases, depending on the severity, we may need to give systemic steroid, and patients should always be closely followed up, evaluated by retina specialists to rule out any infectious causes. On rare severe cases, we may have to go for a surgical intervention by corneal transplantation, or sometimes glaucoma filtration surgeries may be required, or both may be required. Now coming to the complications which can occur in TARS, it could be a severe inflammation, pain, visual loss, iris atrophy with dilated irregular pupil. There could be a corneal endothelial damage and corneal edema which may be sustained, and trabecular meshwork damage will lead to increase in the intraocular pressure and secondary glaucoma. Now coming to the prognosis, The eye pressure, the level of inflammation, the corneal recovery should be observed carefully, and all cases gonioscopic examination is necessary to rule any retained lens fragments following the surgery. Most cases of TARS are successfully treated with topical NSAIDs and topical steroid drops. If the resolution doesn't occur within 6 weeks, the permanent damage is more likely to be occurring with intense inflammatory reaction causing corneal endothelial damage and sustained corneal edema, iris damage with dilated irregular pupil and iris atrophy, trabecular meshwork damage with increase in the intraocular pressure, and possibility is secondary glaucoma. All these things may lead to resultant visual loss. Now, coming to the causes, the substances that accidentally enter the eye during or after the surgery. This could be topical antiseptic drops, this could be topical anesthetic drops, powder from the gloves, particles which are there in the tray, lint from the drapes, air contaminants, plain water if it is used during washing of the instruments, preservatives in the solutions and medications which are used during the surgery, topical ointment which is used after the surgery with a tight bandage. This may gain and entering into the anterior segment. Then substances that are introduced as a part of operating room procedure, like improper irrigation solutions like the balance salt solution, inappropriate pH which is not maintained properly, chemical composition of the BSS solution, osmolarity of the BSS solution, addition of medications and antibiotics which are used during the surgery, toxic preservatives in the BSS solutions like the benzalkonium chloride, sometimes contamination of this BSS solution during the manufacturing process, or addition of any drugs like epinephrine or antibiotics in the BSS solution, or sometimes usage of outdated BSS solutions, antimetabolites like mitomycin C which is used sometimes in surgery, contaminants in the intraocular lens either during the manufacturing process or during polishing of these IOLs or during manipulation of this IOL. There could be powder which could be left behind in the IOL from the gloves. Then irritants from the surgical instruments due to improper cleaning or sterilization process, like dry blood or debris which are left in the instruments, tissue or dry viscoelastics which are left behind in the instruments during cleaning, irritants from the deterioration of the instruments which is reprocessed or reused frequently, residue of detergents used in washing the instruments, then coliforms and metals which are left behind in the instruments, the endotoxin which are released from the dead bacteria, sometimes oxidized metal deposits, and ethylene oxide gas which is there in the instruments during sterilization procedures. This may cause this syndrome. Now, coming to the treatment part, which I already mentioned, once the task is confirmed, patients should be started on topical steroids. Careful assessment of the treatment of elevated IOP has to be checked, and if the IOP is raised, anti-glaucoma drops has to be instituted, non-steroidal anti-inflammatory drops has to be instituted, and a close follow-up has to be taken. In all cases, we should do a aqueous culture to rule out any infection, and in some cases, surgical care may be required, which are severe cases where the intraocular pressure is not getting controlled or the corneal endothelial damage is there with sustained corneal edema, where we may have to uh, exchange the intraocular lens which is introduced, and corneal transplantation may be required, and trabeculectomy may be required with sometimes valve procedures to reduce the intraocular pressure. Now, coming to the conclusion, it's a rare but potentially devastating postoperative problem. A differential diagnosis from endophthalmitis is imperative for proper patient care. Awareness of the etiology, analysis, and treatment of this syndrome is very essential, and scrupulous attention to all the details and protocols are to be followed to prevent any future outbreaks. Just because something is sterile, it doesn't mean it is non-toxic. Thank you. So please do subscribe the channel, and if you have any queries, please comment on the comment box.